Hello, good evening, everyone. Welcome to our 365 Live. So, 365 Live is a platform where we educate the public on the cancer and encourage a cancer prevention lifestyle. So whenever you see this logo, 365 Live, you will know that it's from 365 Cancer Prevention Society, and we are having a live broadcast. So thank you everyone for spending your time, especially Saturday night, with our Facebook live session. So my name is Hui Xin, and I will be the host for tonight's live session. So today we will talk about colorectal cancer screening, why, when, and also how. So you will learn about the types of colorectal screening and the pros and also cons. So this talk is specially brought to you by 365 Cancer Prevention Society and our esteemed medical partner, the surgeons. So 365 Cancer Prevention Society was founded in 2003 as a social service agency with the IPC status, and we are a full-fledged member of the NCCS. So we aim to serve the community through holistic cancer prevention measures, through our health and also nutrition education programs, promotion of healthy lifestyle, and our lymphatic detox exercises. So we also provide practical and emotional support and care for our cancer fighters through our residential and hospital visitations, counseling, nutritional consultation, and wellness services. So as you can see on the screen here, please like, share, and also comment on all our social media pages for the latest updates on our events and activities. So before we start our talk today, please kindly note that all the information shared at this event by the speaker and 365 Cancer Prevention Society are general information only and subjected to changes. So feel free to consult your doctors or any medical professionals for your individualized and detailed medical advice. Thank you. So before we begin, I would like to introduce a campaign launched by 365 Cancer Prevention Society named My First Memo. As you may know, breast cancer is one of the most common cancers in Singapore. Hence, we launched My First Memo to raise funds for women over 40 years old from low-income background to go for a sponsored mammogram screening. So it includes pre and also post consultation to help early detection of the breast cancer as well as provide early treatment. So the donation tiers start from $10 and can go up to $50 and $100 as well. We will appreciate your kind donation. And now you may take out your phones and take a picture of this slide or even scan the QR code shown here to make your first donation. So you may also enter the link shown on the screen into your web browser if you are unable to scan this QR code. So probably we'll give you a few seconds, okay, to do the screening or the scanning as well. So do donate generously, as your donation will go a long way in helping any daughter, mother, or even caregiver around you to receive the treatment and support what they need. Yep, and not to forget, a special thank you to our sponsor, Icon Cancer Center, and our supporting partners, Satacom Health and Early Medical Center, for making the mammogram screening possible. So thank you everyone for those who have done your donation. So without further ado, let us welcome to the next speaker, Dr. Chew Min Ho. So Dr. Chew is a senior consultant in general and colorectal surgeon department in the Surgeons Mount Elizabeth Hospital. So let us welcome Dr. Chew for tonight's topic.
Hi, thanks, Huisin. Thanks for the very kind introduction. And good evening to everyone. Thanks for joining us for this talk. And I would like to just share screen as I prepare to give this very important topic to everyone here. I think it is still very relevant for us. I think many of us are familiar with this topic, colonoscopy screening. But I think sometime last year, there was quite a few news articles that sort of made things a little bit controversial. And I'll touch a little bit on this. The topic I have today is colonoscopy screening still necessary? And I'll go through the who, why, when, and how that we do so. Just a little bit introduction of myself. As Hui Sin has mentioned, I'm a colorectal and general surgeon. I do minimally invasive surgery. We also have a lot of aging population, so we do look at the advances in managing elderly patients for colorectal surgery. I used to be the head of department in Sengkang Hospital. At the time, I was not only the head, but also the division chair and helped to build Sengkang's general surgical department a few years ago. I also am active in both the region and Society of Colorectal Surgeons Singapore, and I'm currently the president of the society. I have no financial disclosures. So very quickly, this was the article last year. This was published in New England Journal of Medicine. This is one of the largest medical journals that a lot of us read. This title called The Effects of Colonoscopy Screening and the Risk of Colorectal Cancer-Related Death. The conclusion was that screening fails to lower the risk of colon cancer deaths in 10-year US study, and this was published in the Straits Times on the 11th of October 2022. Now, in CNN, Bloomberg, and various other places, they also then question the effectiveness of these colonoscopies, and that it says that it fails to prevent colonoscopy cancer deaths. So this was very, very controversial. Um, Now, this obviously has some mistruths, and a lot of us rebutted this, and I'll elaborate a little bit longer. Now, colorectal cancer remains the number one cancer in Singapore. For both men and females, the overall is still the overall ranked number one. For females, the number one cancer is breast, number two is colorectal cancer, but together it is the highest cancer incidence in Singapore. Um, as you can see, the survival is still not very, very good. The 5-year overall survival for colorectal cancer for both males and females is 60 to 61%. And the main reason is that many of the cancers diagnosed remain at the advanced stage 3 and 4 colorectal cancer. Okay. The public has been advised that you should go for regular screening, stop smoking, have diet, exercise regularly, and of course, reduce alcohol consumption. But yet, despite this, we still see a high incidence of colorectal cancers and also an increasing incidence in young colorectal cancers, both in Singapore and worldwide. These are some of the few famous people with colorectal cancer: the former US President Ronald Reagan, the Queen Elizabeth, who just passed away, Singapore's Ke singer Chen Jinlang, and some famous actors, actor Chadwick Boseman, also who passed away last year. And last year during the World Cup, Pele also passed away. Now, he didn't die from colorectal cancer, but because he was elderly, he suffered from the side effects of chemotherapy and passed away sometime just after the World Cup last year. A very quick overview: what is the colon? Colon or 大肠. Okay, so the colon is a U-shaped organ here in the screen in the picture that you can see. It helps to remove waste, and we divide the colon into these various segments of the intestine: the ascending colon, the transverse colon, the descending colon, sigmoid, and rectum. And the majority of colorectal cancers are found in both the rectum and sigmoid, and this amounts to about 60% of the colon cancers that we diagnose in Singapore and worldwide. So where can the cancers form? And actually anywhere: ascending colon, transverse, descending, sigmoid, and rectum. But the symptoms can vary based on the site. And many a times in the rectum, for example, you find symptoms such as the urge to defecate but unable to, or sometimes you may even lose control, known as incontinence. And I'll go through some of the symptoms that you may face when you're having colorectal cancer. The stages of colon cancer are divided into four. Four is the most advanced, of which cancers have already spread beyond the beyond the colon itself. That means it's metastasized to the lungs, the liver, sometimes even to the bone and abdominal wall. And these are usually not curable. And less than 8 to 9% have 5-year overall survival. Stage 3, as I mentioned, is also advanced colon cancer, and this is because of the presence of lymph nodes, and many will need chemotherapy when they're diagnosed at stage 3. So how do colorectal cancers present? Now, many a times there are no symptoms, 无声无息. That means they're there, they're small, they can only be diagnosed in early screening. Okay, but sometimes you may have an irregular bowel. And what does it mean? So when you have change in bowel habits, for many of us clinicians, we diagnose this as something beyond 3 to 4 weeks. Now, the normal stools that we can see in this Bristol stool chart are that of type 3 and 4, and this is the shapes that we like to see. Many times patients have constipation, type 1 and 2 stages, or the grade 6 and 7, they're very watery, mushy stools, and there can sometimes be changes that occur within 3 to 4 weeks, and that is something we must be very careful about. How can the changes, what do the changes look like? So sometimes it may be pencil thin, or what we know as reduced in stool caliber, or you may see your stools becoming hard and dry, or becoming too liquid, or very, very small lumps. Now, why does this happen? So in this illustration here, as you can see, as you pass your stools through the colon itself and it reaches the cancer, it gets blocked and narrowed, and the stools then become reduced in size, and this therefore forms what we call a reduced stool caliber stool or pencil thin. Often that means the colon is on the left side of the rectum or sigmoid, and that is reduced in stool caliber. Sometimes you may see blood in the stools, and why does this happen? Again, the stools, once it reaches the cancer, may rub against the cancer itself and leads to blood formation. Sometimes it's also because of constipation that you're straining, that your hemorrhoids or piles, otherwise known as 痔疮, may actively have bleeding, and this results in blood coming out in the stools itself. Anemia or pink shirt, this is when you have low blood count. Now, these are very subtle features. You may feel sometimes a little bit more tired, lethargic, or when in very serious conditions, when you exercise, you may feel more tired, easy fatigability, sometimes breathlessness, palpitations, a sense of lightheadedness, or just very, very tired on the day. And this may be caused due to low blood count. Now, low blood count can occur in many scenarios. Sometimes in ladies, you may have even having menses, but often we worry about internal bleeding, either from the stomach or colon itself. And colon cancers can often lead to low blood count. Tummy pain, this pain that doesn't go away, it keeps recurring despite treatment, and this one often needs medical attention and evaluation. And sometimes if you press yourself, you feel a lump in the abdomen, please seek urgent care as well, as sometimes there may be a growth of cancer in the tummy. So what can I do to prevent colon cancer? This is the standard that we often advise: reduce or stop smoking, drink alcohol in moderation. And by what we mean, not more than 2 pints a day, which means not more than 2 glasses of beer, and this is usually an average number. And some of my patients say, Doc, if I don't drink from Monday to Friday, can I then top up everything on Saturday and Sunday? So that's also not advisable. You don't drink 10 to 14 pints suddenly in one binge drinking over the weekend, for example. Okay, and this will harm not only the colon but also other important organs like your liver as well. A balanced meal, and it means a variety of fruits, vegetables, and whole grains. But often we also advise not to eat too much fiber, otherwise that leads to a lot of gases, bloated tummy, a lot of distension, and sometimes a very uncomfortable feeling as well. And when we do that, this is what is recommended by Health Promotion Board. Adequate servings in the meals, but nothing too much, and you must eat a balanced meal as well. Exercise has been proven to be highly important, not just cardio, but also resistance training. And the MOH now recommends up to 180 minutes a week. And it has been shown, in fact, not only to prevent, but also reduce colorectal cancer recurrence in our cancer survivors. A good weight is always important, and this reflects your healthy living and healthy exercise. And of course, the recommendation is to go for regular screening. Now, in Singapore, the recommendation begins at 50 years old, and I'll touch a little bit about the FIT or fecal immunochemical test, and of course, the very important colonoscopy. So, some of the frequently asked questions I get: what is a screening colonoscopy? Should I have a screening colonoscopy? Is it painful and very uncomfortable? I'm very scared of going for the colonoscopy. And what does a colonoscopy look for? Can things go wrong? I heard it's very harmful. I shouldn't go for it. So the definition of screening refers to us examining a patient who currently is asymptomatic or no symptoms at all. In so doing, we aim to detect the disease before they become cancer or to detect the cancer at an early stage. Detecting the disease before symptoms occur will improve a patient's chance of cure. Now, bear in mind there are very few cancers that we can screen regularly. Okay, things like breast cancer, cervical cancer, we have mammograms, pap smears. These are very good to detect cancer for the breast and cervical cancers. But colon cancer is not so easy because it's rather invasive. Sometimes patients find it very uncomfortable to do so. So the FIT is something that has been recommended to do yearly. Okay, so as you can see from this picture, what we often tell the patients to do is to pass and collect the stool. You have to sit on the toilet bowl facing backwards. You line a piece of paper in your toilet bowl. You open your bowels and you poop onto the paper. Then you use this stick and you poke into different areas of the stool to try and sample the stool into this kit before you send it off to areas at the Singapore Cancer Society to analyze for you. Now, if it's positive, it may suggest that it's colorectal cancer or some form of polyps that are bleeding inside. But it's not always true. Now, but some of the advantages are that it's cheap, it's non-invasive, and of course you can repeat this over and over again. But when a FIT is positive, we will recommend a colonoscopy because the chance of advanced polyps in positive fit is about 20%, and the chance of a colorectal cancer is about 5%. But of course, there may be false positive, or it may be positive from other sources, such as very commonly Pals of the tongue or diverticular disease. It can be false negative, and you must bear in mind not all cancers bleed, and they may not bleed every day as well. So the day you collect the stool, if it's negative, it may not be symbolic of what is actually happening inside. And of course, the compliance, how you collect the stools, is very difficult, and the process that I mentioned is not always easy to do for everyone. So what is a colonoscopy? Okay, and so from this picture you can see we insert the scope from the bottom of the anus right to the area called the cecum. This is at the right colon. The tedious bit is we need to clear the bowel, 洗肠, clear all the stools, and you need to pass motion 10 to 15 times. And the reason is we need to be accurate to spot these things called polyps. And this is done together with intravenous sedation, which means you're completely asleep, nice and comfortable. The sedation that we give is not general anesthesia. And so GA is when we put a tube into your mouth and a machine that will breathe for you. But in sedation, you breathe by yourself. This is very short. You wake up after, and it's a day procedure that can go back home after. You don't have to stay in hospital. So these are some of the polyps we detect, and these are magnified on the screen. This measures about 7 to maybe 8 millimeters, and these can be easily removed when detected. In large polyps like this, and I'll show a video later, it's not so easy to remove anymore. We have to use these devices called a snare. We have to cut through, and we sometimes apply clips at the bottom, and this is to reduce the risk of bleeding. Now, larger polyps obviously have a higher risk of colorectal cancer. Why do we remove polyps? In this slide, you can see that the transformation from polyps to cancer can occur over many, many years. This is known as the multi-hit hypothesis. There's genetic transformation and damage both from environmental such as diet, lifestyle, smoking. The polyp will then transform from a small one to a big one, and sometimes known as an advanced polyp. And finally, the tumor suppressor gene P53 is lost and it becomes a colorectal cancer. On average, it takes about 5 to 10 years, but it can sometimes be much faster, especially if their family history or the polyp itself is more aggressive. So on average, it's about 8 to 10 years, but it can obviously be faster, and we always aim to remove these abnormal polyps before they have transformed to colorectal cancer. So regular screening and removal of the polyps will reduce your risk by up to 90%. Now, it may not be 100% because sometimes if the bowel preparation is very poor, there's a lot of stool, the detection of the polyps may not be seen, and that's why a colonoscopy may never be 100% accurate. Nonetheless, so let me go back to this study. Okay, so this was a very alarming study that all of us read and was very concerned because we felt it was very misleading. And so I got a lot of questions at the time. Is colonoscopy screening still necessary after this? So we wrote a letter to the forum, okay, and the conclusion that we wanted everyone to remember is that screening is still the best method to reduce the risk of colorectal cancer. So we analyzed this study a little bit, and I'll try to break it down in a simplified version. Now, this study in New England Journal involved Poland, Sweden, Netherlands, and Norway, and a large number of people, 85,000, both men and women, and this was patients who were followed up over 10 years. Now, how the study was done was they were invited everyone to take part in screening colonoscopy. Okay, and there was also a group that did not receive any invitation, and so they wanted to analyze if you were invited, how did you do, and if you were not invited, how did you do? Okay, so it was very significant because it was a 10-year follow-up study. Now, for those who were invited, only 42% underwent screening. Okay, and this about 1% was diagnosed with colorectal cancer. In fact, the screening group, it was observed that 18% of the invited group had risk reduction of colorectal cancer. But because of the way the statistics were analyzed, in fact, the overall survival for both groups had no change. Okay, and this was the conclusion that was picked up in the press and reported, which was obviously inaccurate. Now, some of the criticisms that all of us wrote in, the participation rate was very low, as you can see, very varied among countries, which is quite common for many of these invitational studies, and therefore the true benefit of screening cannot be interpreted correctly. Also, I think some of the criticisms that we read was that the colonoscopy's detection rate of polyps was not as high as the benchmark of 25% that we are familiar with. And in fact, so some of the criticism was that many endoscopists may have missed polyps during the initial screening colonoscopy. And also the way the statistics were done, because of this term called intention to treat, many of those who declined invitation were in fact analyzed together with those who had invitation. So this was also incorrect, and therefore a lot of these patients were lumped together in one classification. So in fact, when we looked at those who had screening, and this last line is the most important, 31% had risk of reduction of death, and for many, many patients had reduction in colorectal cancer occurrence as well. Okay, so the take-home message from the study that was in fact not reported was that colorectal cancer risk reduction from screening is at least 31%, and the risk of death reduction was in fact up to 50%, which is very significant in many of those who had gone for regular screening itself. So how often should I be screened? Now, based on the Singapore Ministry of Health guidelines, if you're on average risk, which means you have no family history of colorectal cancer, Or you have a family history where the cancer is limited to non-first degree relatives, which means not immediate family members like your brother, sister, or father, mother. The screening should begin at 50 years with one colonoscopy and then a yearly FIT. If you have a family member that's a first degree relative, then you're considered at increased risk, or you have a previous history of colonic polyps. Then the screening should begin 10 years before the age of diagnosis of your first degree relative. So, what I mean is, for example, your brother has been diagnosed with colorectal cancer at 45, you should therefore start screening at 35 years old, 10 years before the age of diagnosis of your family member. This is to arrest the development of the polyp before it transforms to colorectal cancer. So I just want to share this. This was published in the news. This was Ipin. He was my patient many, many years ago. He came to me at about 16 to 17 years old. He was in a very good school, but he had recurrent tummy pain. And in fact, his parents thought he had, because of late nights, playing computer games, not eating well, and thought it was the routine gastric formation. But when he came, we examined him and he had a large tumor in the right colon. At the time, he was 17 years old. It was very shocking to him and his family, and he had colorectal cancer surgery. It was diagnosed to be stage 3. Now, in fact, he has no family history at all. No one in his family had colorectal cancer. He has a twin brother as well. Happy to say, after surgery, he had chemotherapy. He did very well in his A levels. He became a scholar, and he is cancer free. And this is about 8 years after diagnosis. So my message is colon cancer doesn't just occur in the elderly. It can occur in the young, even if you have no family history. So it's very important to analyze your symptoms and to seek medical attention early if it's persistent. So while MOH argues that you should start screening at 50, in fact, the American Cancer Society is advocating you should start screening at 45 years old. And this is echoed in some European and Australian countries as well, that screening should begin at a younger age at 45. And many times it's because we're seeing younger and younger cancers occurring around the world. So, how do we prepare for a colonoscopy? This part is probably the most important. Everywhere you go, public or private hospitals will advise you how to clear your bowels thoroughly. You have to undergo what we call a bowel preparation. In various places, it can be 2 liters or 3 liters, and will give you a lot of volume to clear so that the colon is nice and clean like the picture on the left. If the colon is very dirty like the picture on the right, it's inevitable we can't see clearly and we may miss very important polyps to be removed. Just like this picture, we want your stools to be as clear like urine on the right, and that means you're ready for a colonoscopy and your diagnostic test is then very, very accurate and clear. There's small things as well. We'll prepare what we call a low fiber diet for about 2 days. You must stop your blood thinners. It depends on your doctor or cardiologist advice because we want to reduce the risk of bleeding. Please stop the alcohol or smoking at least a few days before because it may affect your sedation and you can't sleep and be comfortable during the procedure. Even Chinese medicine or even supplements like fish oil, ginseng, turmeric acid, all this increases the risk of bleeding. So please stop for at least 5 to 10 days if possible prior to your endoscopy. And so, what are the risks? And in conclusion, these are very, very low and very, very rare. So, this is published in the MOH cancer screening guidelines. While worldwide, we say the risk is about 0.1%, in Singapore, it is much less than that, 0.03% of risk of bleeding. And if there's perforation risk, which means there's a tear, the risk is also very low at 0.03. That is about 3 in 1,000. So what happens if you bleed? If it's a big bleed, sometimes we may have to rescope urgently to find the source of bleeding and to because the blood doesn't clot very well once you remove the polyps. Perforation, which means there's a tear, this can be very serious. Feces comes out, you may need urgent surgery to repair to prevent any dire infections from occurring. So what are some of the alternatives? And they tell me, Doc, I'm very scared of scope. I really don't want to do a colonoscopy. So there's this option known as a CT colonography. So this is different from the standard CT. It's a 3D fly-through like you can see on the screen here. But in the image that you can see, it's like a cartoon in the middle of the picture. The polyp may look like a cartoon, and you still need a colonoscopy to remove this polyp. And that you still need to do a bowel preparation to clear, otherwise the stools will mix and you can't detect the polyps accurately. And also there's radiation dose. Now it can be almost 700 to 800 times that of a chest X-ray. So the accuracy is a little bit lower, about 85 compared to 95%. Yet there's radiation dose, and you still need a colonoscopy to then remove the polyp after that. So in my practice, I only do this in patients who are at much higher risk. For example, had a recent heart attack and stroke, they're on blood thinners that can't be stopped because they may cause problems with the heart stem, for example. And then when we do a CT colonography to do as a part of a screen, but they may need a definitive colonoscopy if they are found out to have polyps or there's a symptoms because of accuracy that we need to then be confirmed that there's no issues. Okay, so this is a video I want to share. Okay, and this is how a colonoscopy is done. This gentleman is my patient. He came to me basically for screen because he's 50 years old. Now, during the scope, we found this large 2.5 to 3 centimeter polyp. As I mentioned much earlier, we have to use these tools known as a snare. We put this around the polyp, and we are limited if the polyp is very large, and we can't do so. During the process of removing the polyp, we use electrical current known as diathermy, and we cut through, and this helps to seal and prevent any bleeding if possible. As I withdraw the scope, you can see the stalk of the polyp is very thick, and there are blood vessels inside there. I then have to apply a clip on it to reduce any risk of bleeding. Now, sometimes these polyps may harbor cancer, so we then have to make a mark known as a tattoo. Okay, and this tattoo is to place a small ink stain on the colon to show me where the polyp has been removed. This is in the event that the polyp biopsy comes back to be colon cancer, and we then therefore need to do surgery to remove. Because once you remove the polyp, you can't tell, you can't feel anymore where the exact site is. So this is to give us a precise location. After we remove the polyp, we use this thing called a rough net. It's like almost going to Hai Di Lao, bring out the fish ball, and then we pull it out gently out to the anus, and then we send for biopsy and testing. Okay, so this very large polyp you can see can be technically sometimes quite challenging, and some patients will have multiple polyps, which take some time to remove as well. Okay, fortunately, this polyp was benign, which means it's non-cancerous, but an advanced polyp, and we recommend the scope quite early again to ensure no recurrence. So these are some of my colleagues, doctors and dentists who have had scopes, and they often try on social media to encourage their own patients and friends to go for early screening colonoscopy. Now, just to end up, this was a Straits Times article in January 2nd, and I think it was a very important newspaper article that actually showed that South Korea and Israel as well have one of the best colon cancer survival rates. If I draw a circle around here, most of the cancers are diagnosed, in fact, at a very early stage 1 and 2. And this is in sharp contrast to Singapore, where many are diagnosed at stage 3 and 4. And in this article, they rightly pointed out that it's because South Korea has invested a lot of resources to promote and encourage people to go for the screening at much earlier age and time. So I think the results show for itself, and the 5-year survival is really remarkable and something that many of us emulate. So for many of us, we are looking forward to the government's Healthier SG launch. I think it is the right move to move into preventive cancer screening, and certainly this talk is to remind everyone that colonoscopy screening is still very important and relevant. Now, I come to the end of my talk. I'd like to thank all the organizations here, Cancer Society, 365 Cancer Prevention, HPB, and of course the Colorectal Society community for their efforts in colorectal cancer prevention. My name is Dr. Chiu. I'll be happy to answer any questions. Thank you very much for your kind attention.
Yeah, thank you very much, Dr. Chiu, for your comprehensive and informative content. So I believe that
Thank you.
through today's session and also the sharing about colorectal screening and also some of the myths that probably the public is still having, like, oh, is it very painful? And also what are the pros and cons and the accuracy level of the screening as well. So I hope that everybody has learned a little bit more, or got a bit more knowledge about, oh, what are the current screening methods, and also what would be the best time, and also how frequent that we are supposed to go for the screening. So probably now, let's take some questions from the floor. So in case anyone has any questions, feel free to comment in our chat box, and then Dr. Chiu will be more than happy to answer anyone's doubt or any questions. So probably before we are waiting for the public to share the questions, I actually have a few questions in my mind. So I think very interestingly to know that colonoscopy is still the best method with the 95% of the accuracy to screen the colorectal cancers. And we do understand that MOH currently recommends every 10 years for those above 50-year-old to conduct the screening. Just out of curiosity, if let's say every 10 years that only we do the screening through colonoscopy, will there be a chance whereby, during the mid-year or any time in between the 10 years that the chance will be missed out? Like, for example, someone really has the polyps and then not be detected by the bleeding through the FIT test, and then just so happen that and asymptomatic, and then only 5 years later they only discover through colonoscopy. So would that be, a lagging time that the colorectal cancer cannot be, found or captured? Just out of curiosity. So probably Dr. Chiu.
Yeah, I think that's a very good question, Hui Xin. Honestly, it's often hard to say for certain can cancers occur after a colonoscopy, and many patients who have had scopes, they have cancers that form maybe 5 to 8 years after. I think there are many challenges when we do a colonoscopy. Firstly, of course, as I mentioned, the bowel preparation needs to be good. Of course, the skill level of the endoscopist needs to be there as well, and we have many skilled endoscopists around the whole island, certainly. Um, why is it 10 years? Often it's because of a resource issue. If we ask everyone to go every 5 years, our hospitals also cannot cope. And even today, because of the long waiting time, say polyclinic, then to see a doctor, then to scope, it can be as long as 3 to 6 months. And everyone is doing the best to of course, keep up to the need. So I think in countries like South Korea, they've also branched out to allow many people to have the resource, like fast track or straight of way can list from polyclinic to scopes, and that's what our government is trying as well. So I think my point is it's very important that not to wait to a time to go for scopes, but also to listen to your own body and symptoms. If you have symptoms, please go forth early and don't wait. And so often I tell my patients, it's like servicing a car. You must often check regularly. If not, when the engine breakdown, the cost to the repairing the car is much higher, similar to colon cancer occurring. Thanks.
I understand. Yes, thank you so much, Dr. Chiu. So, all in all, early detection is always the best. So, screening is always the best method to early detect, or at least we can do early treatment in case anything happens. So we have a few questions here. So I think Karen asked Dr. Chiu, hi Dr. Chiu, I would like to check for Link syndrome patient. How often do we need to go for colonoscopy screening? And the colonoscopy that was done by Miss Karen was in May 2022, and it was actually all clean. So how frequent that she's supposed to go for the checkup?
Okay, so just to share what Lynch syndrome is. So Lynch syndrome is one of those hereditary conditions that occur for colorectal cancer patients. Lynch syndrome doesn't just encompass colon cancers. It can also have things like uterine cancers, urethral or kidney cancers, and other cancers as well. And therefore, the screening shouldn't just be for colon cancers. The polyps in Lynch syndrome behave differently from the standard colon cancers. I mentioned earlier in the slides, the standard polyps transform every 5 to 10 years. Sometimes we understand Lynch syndrome, the polyp transformation can be faster at 3 to 5. So in fact, if you have Lynch syndrome, and this is diagnosed with genetic testing, we start screening at 20 to 25 years old, even urine and womb and all that. And the frequency we should scope should be every 2 to 3 years until we ensure the disease state is stable. But this is a very difficult one. We've done some genetic studies and research studies at the time when I was in SGH, and often it's very stressful for the family members as well. But I think it's important to diagnose early and take ownership of this. So for Karen's question, if she has a scope in May 2022 and it's been clear, I would recommend maybe something in 2024, 2025, but nothing, no need to be too worried and kanchong. You don't have to go every year lah. Thanks.
Okay, thank you, Dr. Chu. So I believe it will be like shorter duration and also more frequent of the colonoscopy for the Lynch syndrome patients lah.
That's right.
So Belinda asked, can we use our MediSave to do colonoscopy?
Yeah, so I think maybe just to elaborate a little bit about that, there was a time when if you wanted to go for a screening scope, MediSafe claims cannot be used because they think it's not necessary. So happy to say MOH has changed that. But often we all have a little bit of symptoms. So many of the doctors always book you as a diagnostic scope so your MediSafe can be used. So Medisave can be used not only for the colonoscopy but also for gastroscopy. So it's all encompassing. But often there's a small cash component you have to pay, but most of the time it's more than sufficient. Also, if you have private shield plans or rider scheme, this can be used. Panel or non-panel doctors also can be approached for the colonoscopy screening. Thanks.
I understand. Can thank you very much, Dr. Chu. So we do receive questions asking that if a person does the FIT every year because it's supposed to be done yearly, is there a need to go for a 10-year colonoscopy?
Yeah, I think that's by Panda Xiong. So also had another question, how often should I do a colonoscopy? Yeah, so to be honest, I think it's very good if you do your FIT every year. But FIT sometimes can be misleading. Not all cancers bleed and not all cancers bleed every day. And just to elaborate a little bit about that. So when cancers bleed that you can see, these tend to be on the left colon, 左肠, the rectum or sigmoid. Cancers in the right colon, the cecum, the ascending colon, sometimes is microscopic bleeding that you can't detect on the FIT. And it depends the large amount of blood. Our FIT technology has improved tremendously. So every day we shed a little bit of blood. The new FITs will count the number of red blood cells inside, in fact, and more than 100, they'll call it a positive FIT. So even if you do FIT every year, I would still recommend to have at least one colonoscopy when you're between 45 to 50, and subsequently maybe every 5 to 8 years thereafter. Okay, but nothing too frequent. If your colonoscopy finds polyps, your doctor or your endoscopist will then advise you how frequent you should scope thereafter. Thanks.
Okay, Ken, thank you very much, Dr. Chu. So I think a very interesting question from Ng Wei Ching about AI. So hi, I read in papers that Singapore Hospital got AI to detect the probably polyps in the colon during colonoscopy. So in future or the current practice, will AI be used in private practices too?
Yeah, hi Beijing. I think that's a great question. So this AI, I mean, we use this term liberally. What exactly is AI? As recently in the Straits Times, people have been commenting about ChatGPT. That's a form of AI known as generative AI, which is different from this AI that we have. So the AI, the machine is a standalone box that we use. I was there in the initial use of AI in Sengkang Hospital as well. And what is the one that we use is from this vendor called Medtronic. It's called the GI Genius. So I love the AI. Why? Because for very flat, very small, difficult polyps that we can't see sometimes, there's a green box that appears. And we then take a closer look. If the green box remains and we're confident that it's a polyp, we remove it as well. This AI technology has, to me, been a game changer because we have increased our polyp detection rate, and it's been published recently, the research journals, from about 20% to almost 35 to 40%, and that's highly, highly significant. The cost to the patient also minimal because the subscription is over a year, and most of the Sengkang now installs it in almost all the endoscopy suites. So to your question, do we have it in private hospitals? I understand Farrer Park Hospital has it already. Some of the standalone centers like StarMed also have the device. Mount E, they are also analyzing because there are other vendors like Olympus that have it, but I'm sure it will come soon. And to me, it's a very, very important tool to help in polyp detection. Thanks, Wei.
Yeah, thank you, Dr. Chu. So probably advancing the questions about AI. So what's so beneficial like to apply AI in this colonoscopy rather than using a medical professionals? Is it only because of the cost, efficiency, timing, or is there any benefits regarding to the efficiency, accuracy, or even the effectiveness of colonoscopy?
That's very important question. So I think there are some clinicians who are not on the camp of AI. They tell me what does it actually do is very bothersome. The light that appears is very distracting. They can't really concentrate on the scope. Um, to be honest, I think when we first looked at it, it looked very primitive. But as we use it more and more, we realized the accuracy of it is very, very high. Now, this initially was by 15, 20,000 patients in Italy, and the software is constantly updated. Now, our human eye can look at different colors, but sometimes when we keep looking at the large intestine, like orange and pink and red, it all looks the same. And the worst still, if there's a lot of poop inside, then it gets very difficult to see. So modern endoscopy, we have color change known as narrow band imaging to look at polyps better. And the AI now is an additional enhancement of that to further look at it and study it closer. So I think you rightly summarized, it's not only more accurate, it's also more efficient because as we look at the screen round, and sometimes the clinician can be very fatigued after a whole day of scopes, the AI is like almost a backup tool for our human eye. And certainly as I age become 老花, I will appreciate another tool to help me lah, for sure. Thanks very much.
Understand. Thank you very much, Dr. Just I believe that in future, when the technology advances, so probably in medical field, there will be more AI related technologies that will come into place to assist the professionals to increase the efficiency of all the treatment or the screening as well. Lah.
Yes, that's right.
Yeah, so we have a question from Pauline regarding the lifestyle changes on the the cause of polyps or colon cancer. So is there any specific diet that will be more likely to lead to the increased chance of getting polyps or even the colorectal cancer?
Yeah, a diet topic will last 1 hour. We can talk non-stop, huh? Okay. But if I just break it down very simply, maybe I just use answer in a roundabout way. So many people used to think dietary fiber is a good prevention of colon cancer. Now, this statement, while it's important to say that there's some truth in it, it's not entirely true that if you eat a lot of Thai and vegetables, you don't get cancer. And similarly, if you eat a lot of red meat, all that, it doesn't mean you have a higher risk of colon cancer. Okay, so the interpretation is this now. So when you eat fiber or vegetables, you can pass motion better. It's meant to clear your stools regularly. Uh, But this was because in a very, very long study, many years ago, some scientists went to Africa and they said, oh, because they have very little meat, the chance of colon cancer was low in the African states. And they went to the Western societies, and because they eat a lot of meat, therefore fiber is better to prevent colon cancer. So now we know in modern day diet, that's not entirely true. We have a lot of processed foods, a lot of processed meats. Certainly, few things are quite true. If you eat a lot of preservatives, if you eat a lot of fermented, salted foods, these are always higher risk for the carcinogens and the nitrosamines inside, which means if you eat the red meat and you eat the barbecue, the char portion, these have high carcinogens because of the soot and the fire content. But red meat itself is important for things like iron and other nutrients itself. But what I also want to make a short mention is this thing called vitamin D. So this has been relatively new. Vitamin D is from sun exposure. Traditionally, it's more for osteoporosis, for ligaments, and all that. It's also good for hair loss and healing for the skin. But recently, in the last 5 to 8 years, there have been many studies to show that vitamin D itself have been used to reduce colon cancer recurrence. Okay, and some countries have looked at it. Does it cause reduction in vitamin? Does vitamin D cause reduction in polyp formation as well? Some countries say that it is. Some countries say that it hasn't. In tropical Singapore, it'd be interesting to know that a lot of us hide under aircon, so we hardly go in the sun. Many of my patients have very low vitamin D that need supplements. Okay, so it's something I encourage. Vitamin D rich foods include things like salmon and trout, and fish oil can also enhance vitamin D absorption. And this is probably something quite new and modern that I feel is something to help prevent polyp formation as well. But I won't recommend anyone to be too fixed about eating a lot of fruits and vegetables and avoiding red meat. Everything in moderation has a benefit to your health. Thanks.
Yeah, thank you, Dr. Ishu. So I believe that we have answered Lynette Neo's questions also. What are the potential causes of polyps? So just a summary that all the actually what we call ultra processed food with a lot of added salt, added sugar, a lot like too oily. So all these preserved food would be the primary causes of increased risk of the colorectal cancer as well. So yeah, so now I think weather is good. So everyone, feel free to get your sport shirt on and also go take a sunlight jogging or whatnot in the morning. So at least we can absorb more vitamin D to reduce the risk of potential colorectal cancers. So Wei Ching actually asked, what is the cost of AI colonoscopy now? So is it very much more expensive?
No, Wei Chin. So I think I can't say for certain because I don't actually do the finances for this, but I think because the hospitals often bill different things like the facility fee, the procedures, and of course, if you remove polyps, there are things like consumables are added. The cost, as I have monitored, remains roughly the same. I think on the MOH website, you can see a lot of the bills have been quite standardized. In private, for example, the fees are all within MOH fee benchmark guidelines, so that hasn't changed very much. So I think honestly, all of us are very cost conscious. We don't want ourselves next time to be paying thousands and thousands and thousands of dollars for a colonoscopy screening that's very important. But it's also important for people to get their insurance sorted out in the event you need things for care. Thanks.
Okay, thank you, Dr. Chu. So we have question from Lynette as well. So do we need supplements? So let's say just now we are talking about vitamin D. The latest evidence probably says that vitamin D may be helpful to reduce the risk of colorectal cancers, or even calcium supplements may reduce the risk as well. So in that way, do we really need supplementation to support the colon care? And frankly speaking, by having these supplements, do they really work to prevent or reduce the risk of the cancer?
Yeah, I think supplements is a very interesting topic. We probably are deficient in many things because we are all creatures of habit. We eat the same thing, we like to eat the same things, and often sometimes it's cultural, lah, right? We eat what the family prepares. So what we lack, we often do not know. So personally, I went to do my own stool, what we call microbiome testing, to look at the bacteria inside. In a very simplified format, it determines gut health, brain health, heart health, and all that. But really, it looks at the subset breakdowns of my common diet and nutrition, uh, diet that I commonly take, and what I actually don't have. For example, I may be lacking an important hormone called GABA, which is good for the brain and rest because I sometimes don't sleep very well because of night shifts or emergency work. And then they may recommend some foods to take to supplement that. Specific to colon, I think many a times I think it's important to have good bowel movement and good bowel habits. I have many patients that see me say, "Hey doc, I only pass motion once in 6 to 7 days." The longest I have a patient that came to me say, "I pass motion once in 21 days." Wow, I also a bit scared, huh? So if you don't clear, you feel very uncomfortable. You have no appetite, you feel very lethargic, you don't eat well. So often I think to improve gut motility, probiotics tends to help, but you need the right kind. There are two kinds of probiotics, one for constipation, one for diarrhea. Right, so it's quite important to choose them correctly. Maybe consult your dietitian or clinician to see what is more suitable for you. And there are many, many brands out there, but find one that works best for you. Okay, and it's important to inculcate good bowel habits to avoid problems. And when you eat well, you pass motion well, you have energy. I think then you feel yourself much healthier as well. Thanks.
Yeah, thank you, Dr. Chu, for the answer. So I believe that with Dr. Chu's explanation, it's pretty much covered the questions asked by the ground and also the public. So probably I have actually one question. It's just that once probably like when the colorectal surgeon remove the polyps, right? Will there be any chance that the polyps will regrow, even though we have tried our best to control the diet, to do lifestyle modification, do whatever preventive measures that we can, and in the 10 years before the colonoscopy to be done? And will there be a chance of polyps regrowing?
Yeah, so polyps can be those like I showed in the video, those that look like mushrooms with a stalk coming out. But polyps can also be incredibly flat, just as flush to the intestine mucosa as well. The one that I showed in the video is a bit technically easier to remove. We can put a snare across, we can cut through, we can stop bleeding. But the flat ones sometimes are very difficult. Why? If you can imagine, it's a bit like an iceberg. You only see the tip. We are hard to see how deep it grows below into the intestine wall. So technically, when we try to remove it, we need to raise it. We then need to put the snare in. We also are very cautious about puncturing a hole or perforating the colon. So inevitably, because of safety and all that, there may be some of the polyp cells left behind, and therefore there's a higher chance of recurrence. So the larger the polyp, the more challenging it is to remove, or sometimes more difficult to do the scope for some patients. The chance of having a good polyp removal may be, of course, difficult as well. Some patients who are very difficult to do a complete colonoscopy are those that perhaps have multiple operations. So there are many scars, the intestine is very twisted. If they're not sedated well, sometimes we find it very technically difficult to finish the scope, and sometimes polyps are also hard to remove as a result. So these are some of the challenges we face as endoscopists, and therefore we advise go for a scope early, avoid having large polyps that are very difficult to remove because it's really hard to remove sometimes. And of course, the chance of polyp recurrence is higher after. Thanks.
I understand. Thank you very much, doctor. Again, let's say talking about colonoscopy. So, is there any medical conditions that are not advisable to do colonoscopy for the screening, other than, for example, just now I think, doctor, you mentioned about those that just have done the heart surgery with uh, and who are being given a lot of the potentially, like for example, the some medications that not be able to stop bleeding. So other than that, for example, for those who on stomach bag, for example, or any like surgery or treatment that has been done on the large intestine, any specific conditions that are not advisable to do colonoscopy?
Okay, so I've discussed about elective, that means the planned ones, but certainly in an emergency, massive bleeding, any patient we can do a scope now. Okay, but the maybe to break it down, those that are not suitable for scope, maybe firstly those who can't take bowel preparation, and those who cannot drink 2 to 3 liters of bowel preparation, maybe those, for example, with stroke problems, they can't swallow, and the things that are or nasogastric tube feeding, they may be difficult. Now, the bowel preparation, in fact, is also okay even if you have kidney failure. Kidney failure patients who are on dialysis, they can't drink a lot of water, and so they hear, wow, I must drink 2 liters. Is that really safe for me? And rest assured, the amount of bowel preparation we give, even if it's 2 liters, doesn't get absorbed in, then you get what we call fluid overload. So it's quite safe for that. The second group maybe are those that we can't give sedation now. And that means there are patients who sometimes if we give sedation, we worry about respiratory rate or blood pressure dropping. Now, for some who are very, very big size, BMI 35 and 40, we will get anesthetists in. Then we do it in the operating theater, we monitor, make sure it can be done safely. But these are some of the precautions we take. Sometimes, of course, patients who are bedbound have had strokes. It may be very difficult. We can't do it because they can't understand and we can't do the scope comfortably. So these are some of the patients we may not be able to do colonoscopy. Thanks.
Okay, thank you very much, doctor, for the sharing. So I think all in all, early detection is always the best method. So colonoscopy isn't like what we always thought in the past. It's very painful, not effective, not accurate. So I think for those who are age 45 or 50 and above, so do consider for a test, and also do consult your individual general doctor or even the oncologist or any like medical practitioners before we can proceed with the test and all this checkup. So thank you everyone once again for all the great questions. I hope that everyone benefits from today's sharing. And thank you once again, Dr. Chu, for all your sharing and answering the questions. It's now, let's thank Dr. Chu once again and for Dr. Chu to take a leave. Thank you very much,
Thanks, Hui
Dr.
Xin.
Chu.
Thanks, everyone. Have a good night and have a good week ahead. Thank you very much.
Thank you, Dr. Chiu. Yeah, once again, thank you very much for sharing your professional insights. So at this point, we would like to appreciate if you can complete the feedback form for tonight's session. So we will be more than happy to receive your feedback and comments, and kindly scan the QR code shown on the screen with your mobile device, or even click on the URL link that we are going to share in the comment section so that we can get your comments and feedbacks. So we will pause and on this screen for a few seconds for everybody to scan the QR code. All right, so thank you everyone for those who have done the scanning. So our next Facebook Live will be on the 25th of March 2023, which is next Saturday. So the same timing, 8:30 on our Facebook platform. So on next Saturday, we'll be having Dr. Lynette from Curie Oncology to share with us on the topic Hope on the Horizon for Advanced Breast Cancer. So we will be having Dr. Lynette to share with us more about, okay, what are the things to focus or to take note on the breast cancer, and what are the potential treatment methods, okay, to be done if you're having advanced breast cancer. So feel free to share this Facebook topic to any of your friends, family members, or even your relatives to join us on the next Saturday as well. So once again, do like and share our social media pages for the latest updates on our events, so such as our today's Facebook Live event. So on the screen, you can see our social media platforms like our website, Facebook, our Instagram, So feel free to check it out for all the latest and also updates, any information or even resources that you may find helpful from the oncology point of view, from dietetics, from nutrition, or even from mental health or counseling as well. So once again, thank you everyone for joining our talk tonight. So hope that everybody has benefited a little bit on the colorectal screening methods. So hope to see everyone in the next session. So take care, stay safe, and good night, everybody. Thank you very much.